Okay, as we've had to do in the past, to make up for a little bit of time in the summer semester, I'll be pre-recording the Chapter 18 presentation on the blood. We've had most of this information, quite honestly, in lab last week as we examined the different leukocytes and looked at red blood cells for a moment and looked at the hematocrit. And between that lab presentation and your lab supplement and what you already know from Biology 105, I think you'll find that there's not too much additional information in this presentation about blood. Now, this chapter, along with muscle and the heart chapter, will be the content for the next exam. And there is a Connect assignment to help you with this material, as well as a quiz that you'll find on Connect. That will be like the muscle and heart quizzes do before the next exam. The presentation, I have you skipping over the first few slides, and you'll see I'm just referring to what blood is. You know that it's a connective tissue, you know the functions of blood, and you know about the cardiovascular system. The average adult has between 4 and 6 liters of blood, and of course the liquid portion is the ground substance, the plasma, which is a very clearish, very lightish, yellowish colored fluid, and everything else is referred to as the formed elements, which includes the red blood cells, the white blood cells, and the platelets. If you took a look at a smear of blood, you would see something like on the left, with the majority of the cells being red blood cells, with more rare, larger, darker staining white blood cells. You now know enough to know that those are both neutrophils. And you would also see small fragments. Those are the platelets. So there are a number of different formed elements, 7 exactly. There are the red blood cells, the platelets, and then the 5 different types of white blood cells. So your primary objective here will be to be able to identify the cells visually, know what each cell's primary job is, know their relative size, their relative abundance, and any special characteristics about each one. In lab, we did a hematocrit with the sheep blood, the goat blood, and the horse's blood, and recall that a small amount of blood was drawn up into a capillary tube, was spun in a centrifuge for 5 minutes, and then we looked at how much of the blood was pelleted, how much of the red blood cell volume was pelleted toward the volume in comparison to the entire volume of the tube. And that percentage of red blood cells is referred to clinically as the hematocrit. And recall, we know that there are normal ranges for male and female for the hematocrit, and if the numbers are lower than the expected range, that patient would be described as being anemic or having anemia. If the numbers are higher than normal, then the patient has too many red blood cells and has polycythemia. What we did not discuss in lab were the components found in the plasma. And the plasma is, sometimes you'll hear the word serum. The difference between plasma and serum is that serum is all of the fluid after you've taken blood clots and solids away. So if you were to give blood the opportunity to clot and then remove the solid components, the liquidy left behind it that would now be the serum. Primarily, it is plasma minus fibrinogen. Remember that fibrinogen is the protein, the clotting protein, found within blood. What we have in plasma are 3 major categories of proteins. The albumins, which are by far the most abundant, so A for abundant, and they are the smallest of the proteins as well. Albumins are involved with fluid balance and contributing to the thickness and the osmolarity of blood, and can have quite a significant effect, therefore, on blood pressure. Globulins, the second largest group of proteins, you may know them as the immunoglobulins, are your antibodies, and they are part of your immune system, and there are a number of different types of globulins, which I won't be going into right now. And then fibrinogen, that precursor to fibrin, which can, upon damage to the platelets, become fibrin and then help in the formation of blood clots. All of the plasma proteins, except for the antibodies, are produced by the liver. So any sort of liver damage or liver problems can certainly contribute to blood protein issues as well. In addition to the proteins, there are nitrogenous compounds, that is, free amino acids. These are going to come from your diet or from tissue breakdown. And there are also urea, which is a nitrogenous waste product. It's an end product of the breakdown of proteins, that is, of the catabolism of proteins. And typically the urea is removed in the urine by the kidneys. There's a fair number of nutrients within the plasma, including glucose and vitamins, fatty acids that are floating around, cholesterol, and then, of course, the dissolved blood gases, oxygen, carbon dioxide, some nitrogen gas as well. And then the electrolytes, sodium, of course, being the most abundant extracellular electrolyte, of course, is no different here in plasma. Now, blood is 4 to 5 times thicker than water, or more viscous than water. Whole blood is, and plasma itself is about twice as viscous as water. And again, that comes from the amount of materials that are dissolved within the plasma. So we know what osmolarity is. It's the amount of dissolved particles that are within the blood that are not able to escape. And if, imagine, the osmolarity is too high, remember the phrase solutes suck. So that means that water would be drawn into the vessels and would increase the blood pressure. If instead the osmolarity of the blood is too low, then not enough water would stay drawn toward the blood vessels, and the water would instead be out in the interstitial spaces between the cells, and this would lead to edema. So the body is maintaining an optimal osmolarity of all your body's tissues through interaction between the lymphatic fluid, the interstitial fluids, the blood plasma. So what would happen if you had hypoproteinemia? That is, you had a deficiency in plasma proteins. Well, as you can imagine, and again, the most abundant plasma protein is albumin. So if you had low albumin, or just total low protein in the blood, then which would be the result of extreme starvation, or you could have liver disease, right? In which case you're no longer making these proteins, or there could be a severe burn, in which case you are losing your plasma readily. Then there would be a real problem with blood pressure, wouldn't there? So if you don't have enough albumins, if your albumins are low, then you wouldn't have those albumins to draw water into, and your blood pressure would be much, much lower. Now, that would be a deficiency in plasma proteins from extreme starvation, but there's also kwashiorkor, which is a condition that you'll see in children with severe protein deficiency, and the characteristics you'll see now is very, very thin arms and legs, but a very swollen abdomen. And this is a combination of ascites, or inflammation of the abdominal region, but very, very little muscular development, again because of a protein deficiency. So you know that blood is constantly being produced, and that all of your blood cells, red, white, and platelets, are made within the bone marrow. Every day you're making, somewhere around 400 billion platelets, 200 billion red blood cells, and 10 billion white blood cells. So the numbers are truly astronomical. The making of blood would be hematopoiesis. You'll also see hemopoiesis, as I have written here. So hematopoiesis is the same thing. Now, before there is the bone marrow, the yolk sac, early in development, is the structure that is first making the blood cells in the embryo. And it's from the yolk sac that the bone marrow, the liver, the spleen, and thymus are formed. And so the liver is also making some blood cells early in development, but the liver stops producing blood cells at birth. After that point, it's definitely the responsibility only of the bone marrow. The spleen remains involved with lymphatic production, so your lymphocytes, yes, they are initially produced in the bone marrow, but they will go to the spleen and they'll go to the thymus, and there will be additional development going on there. So within the bone marrow, all 7 of the formed elements are produced, and initially there's a single cell type from which all of the blood cells can be produced. Some books will call these hemocytoblasts or hemopoietic stem cells. They're now more commonly called the pluripotent stem cells. Regardless, these are the cells, the stem cells from which all of the formed elements are produced. And in their differentiation, in their development, these PPSCs will go on to form some colony-forming units. Now, that's an interesting term. If you've taken microbiology, it means something very, very different from what you think of as CFUs, or colony-forming units. So ignore that definition. But CFUs are specialized stem cells that can then only produce one type of formed elements. So the pluripotent stem cells can make all 7. Then you have more specialized colony-forming units. And then we refer to basically two different forks in the road. There's myeloid hemopoiesis, which is blood formation happening in the bone marrow, and lymphoid hemopoiesis, which is what's continuing to occur in the lymphatic organs. So you know the most about red blood cells. You know that red blood cells are very uniform in their size. Remember those numbers? About 7.5 microns across, about 2 microns in thickness. I guess I should draw that more as thickness from here to here. And you can appreciate what a tight squeeze it is for red blood cells to travel through small capillaries. Now, the primary job of erythrocytes is to carry oxygen from the lungs to the tissues of your body, and also a fair amount of your carbon dioxide is also carried by the hemoglobin on your red blood cells. If there are insufficient red blood cells, then it's very easy to become asphyxiated and not have enough oxygen to the tissue. So we must have a constant large number of red blood cells and a constant supply of oxygen. So here are those numbers: 7.5 microns by 2 microns. One of the other characteristics about red blood cells is that as they become mature red blood cells, they lose their nucleus, they lose their DNA. There's no longer any protein synthesis or mitosis occurring. These cells are not able to divide to replace themselves, so they must be made from the stem cells. They also lack a mitochondria, so they have no true metabolism, very, very little metabolism, some anaerobic metabolism or fermentation to produce ATP, but very little need for metabolism. Now, you know that there are different blood types. I will mention that conversation with you today, but that's something you already know from 105. And the blood type when we talk about type A or type B or type B blood is determined by a surface glycoprotein, which is genetically inherited from your parents. There are also cytoskeletal proteins, actin, the same protein we talked about in muscle contraction, and spectrin, and these proteins are going to give the red blood cell both a combination of durability, or the cell must float around for about 120 days, but also it's flexibility, if you will. So there's a lot of squeezing and stretching of red blood cells as they travel through the small capillaries. Again, the major job of the red blood cell is to transport gases, to give the cell an increased surface area. then again, there's no organelles, and there's a tremendous rate of diffusion across the membrane of these cells. 33% of the cytoplasm of a red blood cell is filled with hemoglobin, this protein. And there are 280 million hemoglobin molecules in each red blood cell. The other major protein found in red blood cells is carbonic anhydrase, CAH, and this enzyme, see it ends in ACE, this enzyme produces carbonic acid from CO2 and water. You've heard me say that CO2 plus water makes carbonic acid. Well, that requires an enzyme, and that enzyme is carbonic anhydrase. And you'll see this carbonic anhydrase come up again as we discuss gas transport, especially toward the end of the course when we get to blood metabolism and to the kidneys. The protein that is specialized to carry the oxygen is hemoglobin. Hemoglobin is a complex molecule made up of 4 protein chains or globins, not to be confused with globulins, right? Globulins were the second largest group of proteins found in blood, the immunoglobulins. These are globins, and for example, there are 2 alpha globins and 2 betas, and in the center of each of these, there's this, in this case, this red star-shaped heme group. Now, the heme group is a non-protein group that directly binds the oxygen, and it does that because there is a ferrous ion, an iron ion, at the center. So you can see the Fe2 plus here, and this represents basically that red star that you see, the heme group, and the heme group is what binds the oxygen. Again, 2 alphas and 2 betas, and the oxygen that binds to hemoglobin does so through the iron and the heme group. But there is quite amount of CO2 that also binds to hemoglobin, and it binds not to the heme group but to the globin moiety, the globin group itself. There's also an interesting switch. As a fetus, you have a different form of hemoglobin than you do as an adult. As a fetus, your oxygen supply is delivered through the maternal blood supply. And so the hemoglobin must bind oxygen very, very tightly. It must be able to capture oxygen that is traveling from the maternal circulation to the fetus. As an adult, we have direct access to oxygen through the environment in our respiratory system. And so there's a necessary switch in the hemoglobin. It goes from a totally different gene product from fetal hemoglobin to adult hemoglobin after we're born. Now, I've already mentioned to you the averages that are found in the hematocrit. And so why is it that women have a lower hematocrit or a lower percentage of red blood cells? Well, one, testosterone and other androgens stimulate red blood cell production, and this is to keep up with the higher percentage of muscle found in males. Women have periodic menstrual losses, so the monthly gift also contributes to a lower value, and hematocrit is inversely proportional to the percentage of body fat. And so women by nature have a higher percentage of body fat, and so they have a lower hematocrit. This continuum will help you with that term PPSC, the pluripotent stem cell from which all formed elements are made. And there is one CFU formed by or from the polypotent stem cell. And this is the erythrocyte CFU. So now this is a specialized stem cell, and from it only red blood cells can be made. And then there are going to be some precursors, some erythroblast, followed by a reticulocyte. And notice here in the reticulocyte, you no longer see a nucleus. And then finally the mature erythrocyte. The cells are getting smaller, as you see going through the progress, until we get to our mature red blood cell. I gave you different numbers, not to memorize these numbers as to the number of cells produced per minute or per day or per second, but again, the numbers are pretty astronomical when you think about the number of red blood cells that are produced in your body continuously. What I do want you to definitely know, though, is that it takes 3 to 5 days for these cells to develop through this process, and that once formed, red blood cells survive for about 120 days within the plasma. So again, going back through this continuum, the first committed cell, the first cell type after we leave the PPSC is the erythrocyte CFU, and it turns out that this production of erythrocyte CFUs is initiated by erythropoietin. Erythropoietin is a protein. It's made largely by the kidneys, a little bit by the liver, but mostly by the kidneys. And that hormone is going to upregulate the number of red blood cells. When you get to the erythroblast at this stage, this is when the cell is multiplying or making lots and lots of the hemoglobin. It's also here making a lot of the carbonic anhydrase. By the time we get to the reticulocyte stage, you've lost the nucleus. You see just a bunch of dots representing a fine meshwork, and you know the reticulum, right? You see a lot of endoplasmic reticulum, so we call it the reticulocyte. And there'll be a few reticulocytes floating in your body. Very few, though, because the reticulocytes are quickly becoming the mature erythrocyte. So you've seen that iron is an important component within heme, and so overall iron metabolism would certainly influence blood. If you are low in iron, you are said to be anemic because you can't have adequate levels of hemoglobin formed. So let's take a look at iron. So one gets their iron from the diet. It's a mixture of Fe2 plus and Fe3 plus ions that are ingested in your diet. And the stomach acid is going to convert the 3 plus to the 2 plus. There's going to be a carrier molecule found called gastroferritin. And gastroferritin, obviously gastro, stomach. Ferrous, iron is ferrous, Fe. So gastroferritin, a molecule that's going to bind and transport the iron 2 plus, and it's going to bring it to the intestine and allow for it to be absorbed into your bloodstream. So you can see that the transferritin then, we're going through the intestines here, and it's transferred into the blood, absorbed into your bloodstream. And here, the iron is transferred to transferrin. So iron can not easily transfer through the blood. It must be carried by some molecule. So it's being transferred by transferrin through the bloodstream, and quite a bit of it's going to go to the liver. And here it's going to be stored, and it binds to another protein called apoferritin, which is stored in the liver as iron available. So if you are low in, so the iron is bound to the apoferritin and it's stored within the liver, and this is basically why you've been told that if you are anemic or don't have enough iron, that you should eat some liver. Right? Liver is a really high organ for iron. And then eventually the iron will also be distributed to other molecules within the body to make the hemoglobin. Remember the molecule myoglobin, a hemoglobin-like molecule that carries oxygen to muscle. That molecule also has iron and a heme group as a part of it. Now, again, iron is a very important nutrient. We see it in vitamins. We must have a constant supply of it in our diet because we do lose every day some urine, feces, and to bleeding. We lose some iron. Men, of course, are losing less iron on average than women. Iron, however, is not absorbed very high. So we need to have it. We can't have too much. You may have heard that iron in vitamins is a major toxic molecule. for young children, so iron-containing vitamins are always child safety locked. Now, what I've already said is now here in words if you didn't catch it all. So basically, within your diet, you're bringing in iron. Your stomach acid is converting the Fe3 plus to the more absorbable Fe2 plus. The gastroferritin is then binding it there, carrying it to the intestine. There, the blood will transfer that iron to transferrin, which will then transfer it throughout the body, again, to those critical molecules that require the iron. One that I did not mention yet are the cytochromes. Cytochromes are a series of molecules found in the mitochondria which are critical for energy production. So again, if you are anemic, what do you complain about? You complain about not having enough energy, because without iron, you're not able to make adequate ATP. Other molecules that are necessary for your iron metabolism would include vitamin B12 and folic acid. These molecules are important in allowing red blood cells to divide and have rapid division. So without vitamin B12, you will also perhaps be anemic because you don't have adequate erythropoiesis. Vitamin C and copper also are cofactors. Cofactors are molecules that assist in other enzymes, and to make hemoglobin you must have vitamin C and copper. So again, there are a lot of other molecules necessary in your diet to assist in your overall iron metabolism. Now, the control of red blood cell production is your classic negative feedback. That is, if there is a drop in your red blood cell count, that would cause the kidneys to become hypoxic. In other words, they would not have enough oxygen. And the kidneys, recall, are getting a constant supply of blood. And so it makes sense that the kidneys, therefore, are in charge of, if you will, monitoring the oxygenation level of your blood. And if the kidneys sense that the oxygen levels are dropping, then the kidneys will produce erythropoietin. This molecule is also referred to as just EPO. And so the EPO then is going to travel from the kidney through the blood, go to the bone marrow, and cause an increase in the red blood cell count. This is going to take 3 or 4 days for this process to occur. And there are different reasons why this would occur. One would be, like I mentioned, hypoxic conditions where you don't have enough oxygen in the blood. Of course, traveling to high altitudes would cause this. You can also have this occurring from an increase in exercise. If you are exercising vigorously, then of course your muscles would be using up more oxygen, and you also would have a loss of lung tissue in emphysema. So all of these situations would lead to an increase in erythropoietin and be a reason for increasing the overall process of erythropoiesis. Now, when red blood cells are naturally broken down after 120 days, they travel through the spleen as part of the regular circulation, and there they are broken down by macrophages in the spleen. There, those macrophages are going to digest the membranes and basically recycle the molecule, separate the heme group from the rest of the protein moiety. So the protein will be broken down into the individual amino acids. The iron will be removed from the heme. So there's a very good recycling program here that's going on in your body, recycling the iron group away from that heme group. Now, the heme, remember, hemoglobin is a pigment, right? It's a pigmented molecule. We know that when oxygen is bound to it, that it's red. But what happens is that the heme pigment molecule gets converted to biliverdin, which is green, verde, green. And that biliverdin is then converted to bilirubin, which is yellow in color. If you've ever seen anybody with jaundice, you know that they become very yellow. And this yellow color from bilirubin is actually contributing to the yellow color of the urine. Now, the liver will remove that bilirubin and secrete it into bile, and then the bacteria will create urobilinogen, and this molecule gives your feces the brown color. So we see that the urine and the feces both get their color from breakdown of heme. And that's shown here in this flow chart. That is the iron, which requires B12 and folic acid, is going to be involved with making new red blood cells. Those red blood cells are going to travel around the blood for about 120 days, after which time they're being broken down in the liver and in the spleen. The cellular fragments will simply be phagocytosed. The globins, the protein moieties, will be broken down into the free amino acids and recycled. The heme group, the iron molecule, will be separated from it and reused. Of course, you'll be losing some of that iron to menstruation and to injury and bleeding. And then the heme group, as I mentioned, is broken down and contributes to the colors of urine and the feces. So this little video will run through that whole hemoglobin breakdown for you. As we mentioned in lab, if there is a decrease or a lower percentage of red blood cells, we call that anemia. If there's a higher percentage of red blood cells, an excess of red blood cells, that is referred to as polycythemia. And there are two types that I want to describe here. Primary polycythemia, also called polycythemia vera, and this would be the result of a cancer in which there is cancer in one of the cells of the developmental pathway. And in this process, you can get as many as 11 million red blood cells per microliter. Remember, it should be around 4 to 5 to 6 million. And this would drive the hematocrit up to almost double, to about 80%. There's also secondary polycythemia, not from cancer, but instead related to dehydration. Think about it for a moment. If you have less water in your plasma, then that would, quote, concentrate your blood and drive your hematocrit up. Emphysema, we'll talk more about emphysema when we get to the respiratory system, but you'll appreciate that the lack of oxygenation, the body is going to try to make up for that lack of oxygen diffusion by making more red blood cells. So that will drive the hematocrit up. Of course, traveling to a high altitude location or physical conditioning requiring more red blood cells to feed the muscles. All of these reasons would drive your red blood cell count up, maybe up to about 8 million. That's certainly not a hematocrit of 80. That might be a hematocrit in the 50s or maybe 60s. Now, the problem with polycythemia is that you're increasing the blood volume, right? You're increasing the number of red blood cells, so you're squeezing more red blood cells into a limited space. That's going to increase the pressure as well as the thickness, the viscosity of the blood, and that can lead to stroke, can lead to blood not flowing through the capillaries as smoothly, lead to embolisms, and to heart failure. Now, as far as anemia, I think I've already sort of alluded to this, but anemia would come into three categories as far as the cause. One would be a problem in the overall production of either the process of making red blood cells, erythropoiesis, or in the synthesis of hemoglobin. So this could be, again, some sort of kidney failure. It could be from an insufficient amount of the EPO. It could be from an iron deficiency. So again, if you're iron deficient, you have anemia because of that. It could be from a lack of vitamin B12, one of those cofactors I told you that was necessary. And vitamin B12, a lack of this could be from poor nutrition. And we're seeing more of this inadequate vitamin B12 because the stomach is necessary for forming or for finalizing vitamin B12. And the molecule that does this last step is called intrinsic factor. Intrinsic factor is made only in the stomach. And in patients who have had gastric bypass, when they've had a significant part of the stomach removed, they no longer are producing intrinsic factor. And so the amount of B12 is oftentimes deficient in these patients. So most bariatric patients have to be monitored for their B12 levels. If not, they can get pernicious anemia, which can be a life-threatening anemia. Hypoplastic anemia, again, would cause a slowing of erythropoiesis, and aplastic anemia would be a complete cessation of this process. There also can be anemia from a bleed. So you could have an internal bleed that you're not aware of, maybe in the colon, and so that'd be a hemorrhagic anemia. And so you might be feeling weak, and they can't find any reason, and they do a colonoscopy, and they realize that you're bleeding. Or there could be an increase in the breakdown of red blood cells because of some sort of hemolytic issue. So in other words, the liver and the spleen are progressing the breakdown of red blood cells too quickly, and as a result, you would be overall anemic. So what are the consequences of anemia? Regardless of the source of the problem, overall your tissue will become hypoxic. That is, there won't be enough oxygen, and this can lead to necrosis of the tissue. The patient would be complaining about being lethargic, right? They wouldn't have enough energy. They could be have a shortness of breath, and this, of course, can lead to a life-threatening necrosis when you consider that the tissues aren't getting enough blood. This could lead to a lack of oxygen to critical organs like the brain, the heart, or the kidney. With reduced red blood cells, the blood osmolarity would be reduced, and because there's fewer or less osmolarity of the blood, that means that less water would be pulled into the blood, leaving more fluid out in the tissues, leading to edema. And in this case, the blood's not thicker, the blood is actually thinner. And this can actually drop the blood pressure, and because of that, cardiac failure can be a result. Lastly, in the discussion of red blood cells, we have sickle cell disease. We discussed this a little bit in the past. This is a hereditary mutation in hemoglobin, and more common in individuals of African descent. And normal hemoglobin, about 280 million molecules found within a red blood cell, and the molecules, don't do anything wrong. They just carry oxygen. But if there's the mutation, then we call this HBS, the hemoglobin sickle form. And what happens is that this molecule no longer binds oxygen as well, aka anemic. They don't carry the oxygen, so they're hypoxic. And the mutation in the hemoglobin causes now the red blood cells to get a little bit more rigid, to get sticky. They get pointed at the ends. The molecules themselves are polymerizing. This can lead to a blocking of blood vessels, not a blood clot like a fibrin clot, but it can lead to a blockage of blood vessels. Of course, that can be very painful if the tissues are becoming hypoxic. And of course, if that blockage is going to a critical organ like the kidney or the heart or the brain, that can be very, very significant, and also could lead to paralysis and death. The last conversation I'll have about red blood cells is about blood typing. And you know that the most common type of blood typing is referred to as the ABO blood typing. And it's because there are glycoproteins, glycolipids on the surface of the red blood cells that have been called A and B. These antigens will appear or are on the red blood cells, and to those antigens, antibodies will begin to appear 2 to 8 months after birth with a maximum concentration by 10 years of age. So a young baby's immune system is not yet developed and would not be as critical in a mistransfusion. So if you have the A antigen, then your body would be comfortable with that, its immune system, but would make the antibody against the B and vice versa. You would not form antibodies against your own blood type normally. When an antibody and an antigen of the same type do come in contact, it does lead to agglutination, which is what happens in a mismatched transfusion reaction. And this agglutinated mixture of antigen and antibodies can lead to a blockage, which can lead to kidney damage or other tissue damage. Now, eventually, the agglutinated red blood cells will break down, will hemolyze and release their hemoglobin, but in the meanwhile, it can definitely cause some very significant blood flow issues. So in this particular image, you can see that in the transfusion, that blood from a type A donor was given here, but this person was a type B blood. And so as a result, there's an agglutination, a blocking of the foreign blood with the patient's own antibodies, and this could lead to blockage of vessels. When it comes to the ABO group, there's the universal donor and the universal recipient. The universal donor is O. I'm going to add even more to this. It's O negative. Type O is the most common blood type, and type O negative is the universal donor because it lacks all of the antigens. When one is giving blood, we refer to what's being given as packed cells. There's very, very little plasma when you are donating or being given blood. And so you don't have to worry about the inherent issues with the antibodies from the donor, just the red blood cells. Now, the universal recipient is AB, more specifically AB positive, and this is a rare blood type. It lacks antibodies. This person lacks antibodies, and so they can receive any blood type. Now, there are other agglutination issues. The RH factor, the one that is most concerned about is this one, RHD, and so we'll talk about positive and negative blood. If you have the D factor, the RH factor, then you are said to have a positive blood type. If you are lacking the RH factor or lacking the D antigen, then you are said to have negative blood type. Now, the difference here is that whereas the body will naturally make A and B antibodies by 8 months and maximally by 10 years of age, anti-D agglutinins or antibodies are usually not present, and one must first be exposed to RH positive blood. So an individual will not naturally make antibodies against the RH factor until they have been exposed to RH blood. And so an RH negative woman with an RH positive fetus will, after that point, begin to make antibodies. There would not be a problem, however, with the first transfusion or the first pregnancy. Moving on to white blood cells. These are true cells. They are the least abundant of the formed elements, with normal ranges being between 5,000 and 10,000 white blood cells per microliter of blood. They have no function in oxygen or CO2 carrying, but instead are part of your immune system, protecting you against infectious microorganisms and other pathogens. They have a very obvious nucleus, and that's the way that you've been taught to recognize these different white blood cells. Some will spend only a few hours in the bloodstream before they migrate into connective tissue. And again, they retain all their organelles. So these cells are mitotic. They have a metabolism. Some of the cells are called granules. They have lysosome-like granules that are very obvious. Others, take that back. So all white blood cells have lysosomes, okay? But some of them have very specific additional granules, and these granules are going to release specific enzyme and protein products that will fight off different pathogens. So all white blood cells, to say it again, have lysosomes, but only the granulocytes have additional specific granules that contain enzymes. So let's discuss those granulocytes. Neutrophils, eosinophils, and basophils. Again, the numbers are on here, things you've seen in lab already. And you already know how to recognize these different white blood cells. The A granulocytes, the lymphocytes, and the monocytes. Now notice here that the neutrophil number includes both the segmented and the banded. I'm not discussing that here in lecture. So the neutrophil number is all the segmented and banded together. Now, why do we have these different types of white blood cells? Well, neutrophils are, again, the most numerous, but they're going to be increasing their numbers following a bacterial infection. And so these cells very specifically phagocytose bacteria, and their granules, when they're activated, release antimicrobial chemicals. So they're specifically made to fight off bacteria. Eosinophils, when you hear the word eosinophil, you're thinking parasites. And they also release enzymes, but their enzymes, rather than fighting off bacteria, are more specialized in fighting off parasites. Eosinophils also, parasites are too large to engulf, but they do go around and phagocytose complexes, allergens, and other inflammatory chemicals. Then the basophils, you'll see these numbers increased in some infections like chickenpox or sinusitis, diabetes. And what's specific about basophils is that they release histamine and they also release heparin. And both of these, histamine is a vasodilator, increases blood flow to an injured area, and heparin is an anticoagulant, and that's going to promote the movement of white blood cells to the area. So in these images, you can see, again, these cells are all roughly about the same size. They're 1.5 or so times larger than red blood cells. And you can see here the neutrophils, you recognize those as being two segs. Color here, red granules in the eosinophil, and the blackish blue granules in the basophils. Again, you'll recognize these solid black backgrounds as coming from APR, a great resource to go and look at additional white blood cells if you're struggling with the identification of these cells. Again, that really rich, bright reddish, hot pink, orangey colored granules depending upon the staining. Found in eosinophils, and in basophils you'll see the dark bluish black granules. Now the other white blood cells are the agranulocytes. These include the lymphocytes. Now there are many, many different types of lymphocytes, B cells and T cells, and then many categories of those. But all of these cells are destroying. They can directly destroy foreign or cancer or virally infected cells, and you'll learn when you take a unit of immunology within the microbiology course that some of these lymphocytes present the antigens to other immune cells, and they're just critical to the overall coordination of your immune system. When the lymphocytes become destroyed, as in HIV, then the immune system really tanks and is no longer able to fight off foreign infection. So a lymphocyte, as you know, is going to be characterized as the smallest of the white blood cells with a very circular, solid-looking nucleus that takes up the majority of the cytoplasm. The other agranulocyte are the monocytes. They're going to increase in viral infections. You'll recognize them by their monstrous size, by far the largest. They do have a horseshoe-shaped nucleus, but by far you're going to recognize these cells because of their size. So you can really appreciate that here in this image when you see the monstrous size of this monocyte in comparison to the red blood cells and the lymphocyte. So the making of a white blood cell, or all white blood cells, would be leukopoiesis. Again, we start off with a pluripotent stem cell, the PPSCs, and there are the two different lines here. So there can be myeloblasts, and the myeloblasts are going to form the neutrophils, the eosinophils, the basophils. There are monoblasts, making the monocytes, and there are lymphoblasts, giving rise to the lymphocytes. Again, they're all coming from this pluripotent stem cell found in the bone marrow. Now, white blood cells do not stay in the bloodstream too terribly long. Most of the granulocytes are going to leave within 8 hours of the blood and will live within the tissues for about 5 days. So a person will have an increased number of white blood cells when they're fighting off infection, and then those numbers will reduce. Monocytes will leave in about 20 hours and become macrophages. Now, the macrophages can live for several years. So these cells are long-lived. And the lymphocytes also are long-lived because they're the ones that are going to give you long-term immunity. So the reason you get a vaccination is to activate lymphocytes, which are going to make your antibodies. And those antibody-producing cells are the lymphocytes, some of the B lymphocytes, and they can hang around in your body for decades. So they're going to be around for a very, very long time.
I was holding that in until you stopped talking.
So the top image, you can appreciate normal looking blood. Again, you see mostly red blood cells, and within this one view you can see a really large monocyte. There's a smaller lymphocyte, and here are two neutrophils. In blood that's leukemic, you would see a large number of, you could look at the large number of white blood cells, and not only is there a large number, but they're abnormal. The last formed elements to discuss would be the platelets. Again, they have a completely different role. Their job is in hemostasis, that is the stopping or the cessation of blood bleeding. And their job is to constantly prevent blood from bleeding out and making small blood clots or forming little blood clots within your blood, even where you're not aware of it. There are three hemostatic mechanisms. Now, look at this word carefully. This is not homeostasis, but hemostatic, right? The stopping of blood or bleeding, or hemostasis. So there's going to be the vascular spasm, followed by the platelet plug formation, and then finally the coagulation. And platelets will be important in all three of these. Now, where do these cells come from? Or I shouldn't even call them cells. These formed elements, the platelets, are actually just small fragments of a much larger cell called a megakaryocyte. Now, megakaryocytes, as the name suggests, are cells that are large, with a very large karya, with a very large nucleus. The platelets themselves also contain granules, much like the granulocytes. They move by sort of an amoeboid movement, okay, and their normal numbers are between 130,000 to 400,000 platelets per microliter. Here is the megakaryocyte. We are in the bone marrow. You can appreciate this is a very, very large cell, and you can't see it here, but there are little fragments of it that are blebbing off to form the platelets. Now, again, what these platelets do is they secrete vasoconstrictors that are going to help prevent blood loss. So when there's any damage to a blood vessel, the platelets will release their products that's going to cause vasoconstriction, a reduction in blood flow, a constriction of the blood vessel itself. These platelets themselves will form a plug. They will stick together to form a small seal, and finally they'll lead to the clotting of the blood, so that no blood can move through. So again, those are those three steps. There's the spasm, the platelet plug, and then the coagulation. Now, once platelets have formed the clot, then also the platelets are going to initiate the formation of clot-dissolving enzymes, because you would want to stop the blood flow temporarily, but you wouldn't want it to be forever. So you want to start breaking down that clot as well. Not only are they going to start breaking down the clot, but they're also going to start recruiting other cells, neutrophils and monocytes, and this is going to increase the ability of the body to fight off whatever may have caused that damage or reduce the infection. but also lead to some inflammation. So those neutrophils and monocytes are going to start phagocytosing and destroying any bacteria that would have entered with that damage. And also, the platelets will begin to secrete growth factors, which will stimulate mitosis to repair the blood vessels. So not only are we going to initially stop the blood flow, but we're actually going to be critical in the repair as well. Here is a cartoon representation of a megakaryocyte. You can see how monstrously large it is compared to red blood cells or white blood cells next to it. We're definitely in the bone marrow here. And you can see how the cell has these little fragments that go up into the bloodstream, and these little tiny fragments that are breaking off are in fact the platelets. The total production of platelets would be referred to as thrombopoiesis. Thrombopoiesis, there is a hormone called thrombopoietin, which would upregulate the megakaryocytes to make more platelets. And the megakaryocytes are repeatedly replicating DNA without dividing. So they're just these huge, huge multinucleated cells that remain in the bone marrow. Those are the megakaryoblast, I should say. And then there are the megakaryocytes that are formed from it. Now, platelets will survive or freely float around for 7 and up to 10 days. And 40% of your platelets are actually stored in the spleen at any one time. So let's go through those steps of hemostasis. Number 1, a very quick constriction of the broken vessel. This is almost immediate. Again, there are substances released by the platelet which are vasoconstrictors. Now, what will cause this vascular spasm? So when looking over the overall process of leukopoiesis, that is the making of all white blood cells, what you'll note here is, again, this precursor cell, the pluripotent stem cell. And this cell can go on to form multiple different CFUs. Each CFU is now tied into or committed to creating a different white blood cell. So I'm not going to have you worry about any of the middle story here, so don't worry about that at all. But just recognize that from the same cell, we're going to make eosinophils, basophils, neutrophils. You know those as the 3 granulocytes. You're also going to make the monocytes and both of the lymphocytes, the B cells and the T cells, and all the different types of lymphocytes. You only know them, all of these, as lymphocytes. You haven't learned the individual names, nor will you this semester. So a person, I mentioned these terms in lab, a person who has a lower than expected white blood count, that is below 5,000 white blood cells per microliter, would be said to have leukopenia or would be leukopenic. And this could come from any number of issues. They could have had radiation exposure, some poisons will interrupt leukopoiesis, or some diseases which knock down the white blood cells. For example, you know that HIV starts destroying lymphocytes. And the problem with a lower number of white blood cells is the patient becomes at much greater risk for infection. You could also, if you had more than 10,000 cells per microliter, be considered to have leukocytosis or leukocytotic. And the causes here, again, you might have a disease which is regulating the number of white blood cells, allergy, your body is trying to fight off the allergens, or some sort of infection. So then you could have a short-term leukocytosis, and when you're doing a differential white blood cell count, that is when you are, looking at blood and looking at the different numbers of different cells, you would be able to tell which type of leukocyte is out of normal range, and as we did in lab, predict perhaps some of the issues related to their infections. Now, leukemia, we hear that term, and leukemia would be a cancer of any of the hematopoietic tissues that would give you a high number of any of the leukocytes or any of those precursors. A couple of slides back, I told you not to worry about the individual cells. So I'm not having you name any of these, but you could have a cancer where you have an increase in this cell or an increase in this particular kind of cell. And the problem with that is that now you have this increased number of cells, which is driving the other cells down. And if you have increased number of precursors, then you don't have a number of the mature cells. So again, if you have an increased number in pre-basophils or pre-eosinophils, you would not have enough mature cells. Now, two different types of leukemia, very generally, there's lots of types, but there can be a myeloid leukemia. That is a uncontrolled production of some of the granulocytes. Or there could be a lymphoid leukemia, which would be an uncontrolled lymphocyte or monocyte production. You may also hear about leukemias being acute or chronic. Acute leukemias are sudden onsets, usually progress very rapidly, and the patient, if they don't respond to treatment, can certainly be dead within a few months. Chronic leukemia can go undetected for months, and then even after diagnosis, survival time can be much, much longer. Again, when you disrupt the normal cell percentages, you could have impaired immune responses, you can have impaired clotting, and the onset of opportunistic infections. So as I showed you a picture before, normal blood on the top, you see mostly red blood cells. There's a monocyte, you see how big it is, you see a couple of lymphocytes or neutrophils here, and there's a nice lymphocyte. And then in leukemic blood, you would see a very huge number proportionally of white blood cells, regardless of their type. You recognize that does not look like normal blood. So just a little bit about platelets, and that is hemostasis, the stopping of bleeding. And again, platelets are going to be involved in three different mechanisms to stop bleeding. There is first the vascular spasm, then the platelet plug formation, followed by the actual blood clotting. I'm going to skip over these slides because I realize I already presented these for you, and I got started a little bit early, and I believe that where I should have picked up was right here in hemostasis. So vascular spasm, what happens is that the moment that the vessel is injured in any way, the platelets will begin to release products which will cause vasoconstriction that'll stop the flow of blood. Now, that can happen because there's been injury to smooth muscle. So, for example, let's say you injured a blood vessel, right? And there's smooth muscle around the tunica media of a blood vessel. But it's also possible if you trigger pain receptors. Some of them will cause blood vessels to constrict. And also, platelets release serotonin. You know serotonin as a neurotransmitter, but it's also a vasoconstrictor when released in a localized environment. So immediately then there would be constriction of the broken vessel. There would be smooth muscle. Again, this could be caused by smooth muscle injury or the activation of pain receptors. So in this cartoon, what you see is that immediately there's this vascular spasm, a restriction or constriction of the blood flow. Now the second thing is that you'll see a formation of the platelets form a plug. They're sticky, or they get sticky, I should say, with injury. Normally they don't stick to one another. You wouldn't want your platelets to stick to one another normally, but with injury they become sticky, so that forms a plug. It's also helping to restrict the blood. And then finally the fibrinogen will become fibrin and actually form the coagulation, the actual blood clot. So there's a picture. I'll be describing the platelet plug and the coagulation in the next slides. So normally, again, the endothelium, remember the endothelium is the simple squamous epithelium of the inside layer of a vessel. It's usually very smooth. It's coated with a molecule called prostacyclin. And what this is a platelet repellent. So it's not going to allow platelets to normally adhere to the inside of the vessel, and that's a good thing. But again, once there is damage to the vessel, once there is exposure of collagen, then the exposure of collagen will cause the vessels to become, the platelets to become sticky once again. So the platelets will have these little pseudopods, these little branches coming out of the cell, and they will start sticking to damaged cells and start creating the platelet plug. Also, the platelets, as they are activated, will begin to degranulate. That simply means that they'll start releasing their granular substances. And this is where you find the serotonin in the granules. There's also ADP that will attract and degranulate more platelets. And finally, there is an eicosanoid called thromboxane A2, which also will cause more aggregation, degranulation, and vasoconstriction. So this is an example of positive feedback. There aren't too many examples of positive feedback. Remember, positive feedback is when something begins to happen, it actually starts to roll more and more and more out of control, and it doesn't get tamped back down like normal negative feedback mechanisms. The last step, and the most effective step, is the final actual clotting or coagulation. But before this happened, there was vasoconstriction and the platelet plug. And this is when the fibrinogen is converted to fibrin. So we go from an insoluble protein, we go from a soluble protein, fibrinogen is a soluble protein that's floating in your blood, and then that is converted to an insoluble fibrin. There are other clotting factors involved in this process, and you may have heard of clotting factors found in the blood. These clotting factors are missing or are mutated in individuals with certain forms of hemophilia. And there are many of these enzyme protein clotting factors that are necessary in what's called the extrinsic and the intrinsic pathways. So these are both cascade pathways that will initiate and form, in the end, a beautiful blood clot as you see here. So in this picture, you can see red blood cells, you can see little platelets, and the white blood cells aren't quite as obvious, and then all of the fibers that you're seeing within this would be fibrin. Remember that the fibrinogen has been cleaved and has become fibrin in the blood clot itself. So the actual coagulation involves a number of steps referred to as the extrinsic or the intrinsic pathway. I'm not going to differentiate between these two because they all ultimately come down to this area, which is the same for both. So this is the extrinsic mechanism. There's some sort of damaged tissue, or the intrinsic mechanism where a platelet degranulates. Regardless, though, in the very, very end, this is what happens. In the end, there is a formation of the fibrin clot. Okay? Now, fibrin was formed by fibrinogen. So fibrinogen becomes fibrin. What I want you to know, though, is also this enzyme. And this enzyme is thrombin. And thrombin is the molecule necessary to cleave fibrinogen into fibrin. So know that molecule. And also recognize that calcium is critical. I don't care if you're talking about the extrinsic or the intrinsic pathway. Calcium is necessary for both pathways. You'll see calcium mentioned in the fine print. So remember, calcium is important not only for action potentials and muscle contraction, but also critical for blood clotting. Some of these factors, some of these steps along the way, you've heard of perhaps. Factor 7, factor 10, factor 5, factor 8, factor 7. These are all different molecules that are necessary for normal blood clotting, and in different forms of hemophilia, these factors are missing. So you can see the cascade, if you will, here. So we initiate the blood clotting, and then you need all these factors. You need 12, 11, 9, 8, 10. Don't worry about the order of them, but each of those is necessary. If you're missing one of these factors, then your blood would not clot properly. So that's some form of hemophilia. Again, I want you to see that thrombin is necessary before you get to fibrin. And all of the others have the word factor in them. So they're all, you'll recognize them, they're all somehow involved with clotting,
but do not worry about the order. Okay? Ignore the order of them. So at the very, very end, factor X is also going to lead to the production of prothrombin activator. Prothrombin activator converts prothrombin into thrombin, and then again, thrombin is the fibrinogen to fibrin connection. Again, this is a positive feedback mechanism, and it is moving faster and faster toward having final blood clotting. Now, what happens? In a blood clot, typically the clot will begin to retract within 30 minutes. You don't want to restrict blood flow forever. There's still tissues and cells downstream of that damage that are dying if they don't get oxygen. So we want to retract the clot. And I've already alluded to this, but there are different factors which are going to begin to stimulate fibroblasts and other smooth muscle cells in the area to start repairing the vessel. So there are different growth factors. This is platelet-derived growth factor. Guess what? It's secreted by the platelets. And the process of dissolving the clot is fibrinolysis. So you know that lysis means the breakdown of, so the breakdown of the fibrin clot. Now, you may have heard of calcrein. Calcrein converts plasminogen into plasmin, and plasmin is necessary to break down the clot. So you've got a few molecules to learn here. Make sure you've got track of fibrinogen and fibrin, thrombin, and now plasmin. And plasmin, again, is going to break down the fibrin. Now, I know that they all end in IN. They're proteins. Unfortunately, they don't end in ACE. That tells you it's an enzyme, but these are enzyme-like molecules. So in the full package here, you can see this. So fibrin becomes, you start breaking down the fibrin through the action of plasmin. Plasmin, before it was active, was plasminogen. Okay. So the normal process of breaking a clot is for the body to produce plasmin. Now you'll also hear about plasmin being given to patients who are having perhaps a stroke, and the idea is to break up that blood clot. So in the emergency room, they'll give plasmin-like molecules to break up the clot. You don't want your blood to clot inappropriately. That's why normally your cells, your endothelium is lined with prostacyclin. Again, that's going to keep the platelets from adhering. There's also thrombin is diluted by rapid flowing blood. So you wouldn't want a clot, and you would be able to break it down somewhat if there was any naturally occurring through the thrombin. You also have in your blood natural anticoagulants. So heparin you may have heard about. Heparin will interfere with the prothrombin activator and keep the blood from clotting. And there's also antithrombin, which is made in the liver, which also deactivates thrombin. So again, we've got mechanisms in place. If our blood were to begin to coagulate, we would be in devastating situations, right? We'd be clotting all the time. Deficiencies in the ability to clot blood. You've heard of hemophilia. There's a whole group of these hereditary diseases. Again, there's one or more missing factors. Hemophilia A, which is the most common, is missing factor 8. Hemophilia B is missing factor 9. Hemophilia C, for example, is missing factor 11. So there are different forms of hemophilia missing or having defects in one of these different clotting factors. Nowadays, a person who has hemophilia, they used to have to get blood transfusions all the time. Nowadays, we can actually produce many of these clotting factors through biotechnology. So we can just give hemophilia X factor 8 or whatever missing factor they have. But it's still one of the main things that when you give blood, when you give plasma specifically, they're still collecting some of those clotting factors to give to hemophilia X. And then just a couple more terms. Hematoma would be a large mass of clotted blood in the tissue. Think oma, usually a tumor or a mass. So hematoma would be a mass of blood. A thrombosis would be an abnormal clotting in an unbroken vessel. So a thrombus is a clot. This happens more often in the leg veins of inactive people. Remember that veins are under very little pressure, so it's very possible for blood to accumulate and to clot there. And then that clot, the worst thing is that it can travel from the veins to the lungs and cause a pulmonary embolism, which can be a deadly situation. So an embolism would be anything that can travel in the blood and block the blood vessels. And if there is tissue damage involved, infarction, you can talk about a myocardial infarction or a stroke. Again, you've stopped blood flow going to the brain or to the heart. And cardiovascular disease, clotting, if you will, leading to a lack of blood to the heart or to the brain are major causes of death. So how are we going to manage this? Well, we don't want clots to form by themselves, and we do want to dissolve existing clots. So we have a couple of factors. Vitamin K is required for the formation of your clotting factors. Newborns are given a shot of vitamin K to make sure that their blood is ready to clot if needed. People are given Coumadin or warfarin type molecules, medications. They are vitamin K antagonists. So they're going to fight vitamin K and prevent clotting, right? So these are blood thinners. And the problem with individuals who are on these medications are more prone to bleeding. They're less prone to clotting, forming a stroke or a heart attack, but they do open themselves up to greater bleeding risks. Aspirin, we hear about people taking the baby aspirin, the 81 milligram tablet every day, which is recommended. Suppresses thromboxane A2, and I mentioned thromboxane A2 was one of the molecules that kept your platelets flowing nice and smooth, and so if we suppress that, then we can keep our blood, from clotting. Historically, leeches were used to bleed individuals. Snake venom has been used also. It's an anticoagulant. When some of the snake venom, when you are bitten, your blood will flow rather freely, which increases the toxin traveling through your blood. It doesn't clot off. So I mentioned that in an emergency situation, you can get a plasminogen activator. You'll hear about TPA. And it's very specifically given to patients who are early in a heart attack or a stroke, and again, trying to break down the clot, restore the blood flow. And then streptokinase is an enzyme also used to to dissolve clots in coronary vessels. That brings us to the end of this extra presentation. Again, this was broken into two smaller parts, but you'll find these available for you. Please now make sure you take do the Connect assignments and take the quiz that you'll find on Connect as well.